Welcome back. Today we're doing a deep dive into mandibular reconstruction principles. Let's jump right in.
Okay, so fundamentally, the decision-making process hinges on the defect itself. Location and size are really the primary things.
Right, and you also need to factor in why the defect exists, yeah. Trauma versus, say, tumor resection,
Exactly. And whether that tumor was benign or malignant makes a difference too.
especially with malignancy, because you often have post-operative radiotherapy to consider.
Absolutely. Radiotherapy changes everything. It really pushes you towards using vascularized options, either bone or soft tissue flaps.
Because the healing capacity is just.
Yeah.
It's compromised otherwise.
Precisely. Vascularized tissue brings its own blood supply, which is crucial in an irradiated field.
Yeah. We always have to think about donor site morbidity.
We do. It's always part of the conversation. But, the priority has to be achieving a good, stable mandibular reconstruction.
Okay, so let's walk through some of the initial options. What about just letting the defect collapse? No bone reconstruction at all.
Well, it's an option in certain situations. Think ascending ramus defects or maybe lateral defects where you've resected the condylar head right at the TMJ.
What's the upside there? Faster surgery.
Yeah, faster surgery and potentially preserve speech and swallowing function, relatively speaking.
But there must be downsides. Cosmesis. Function.
Oh, definitely. You almost always get chin deviation towards the defect side, and that throws the bite off. You end up with a crossbite, malocclusion, the original dental relationship is lost.
Okay, so not ideal functionally. What about using mandibular reconstruction plates, MRPs, just on their own?
Right, so these are typically metal plates, maybe 1.5 to 2.4 millimeters thick. You fix them with screws, either locking or non-locking.
And when might you choose that route?
It's sometimes considered for patients who might not tolerate a longer surgery, maybe poor surgical candidates overall, or those with a unfortunately limited life expectancy.
Because it's quicker,
Yeah.
avoids a flap harvest.
Exactly. Speed and no donor site morbidity are the main advantages.
But the material we looked at suggests some pretty significant problems with plates alone,
Yeah, there are major drawbacks. Plate fracture is a really big concern.
which sounds like a disaster midterm.
It is, and it often means you're then facing an even more complex reconstruction, possibly needing a flap anyway, especially if they've had radiation.
And extrusion, the plate poking through.
Yes, high extrusion rates, particularly bad in the anterior mandible, and again, much worse in irradiated tissue.
And the time frame for failure sounds quite short.
It can be. Failures often happen within the first year, year and a half. The mean time is something like 6 to 8 months, and you end up doing more secondary procedures compared to if you'd started with vascularized bone.
Okay, so plates alone are a bit of a gamble in many cases. Let's shift to soft tissue flaps then. What's their role?
Soft tissue flaps are crucial for bringing in healthy vascularized bulk. This helps fill dead space, cover important things like nerves and vessels in the neck.
And prevent fistulas,
Right.
or cutaneous fistulas.
Yes, absolutely vital for sealing the reconstruction and preventing those fistulas.
But the obvious limitation is no bone.
That's the key takeaway. Soft tissue alone doesn't restore the skeletal structure. It doesn't give you back the occlusion.
What are the common go-to soft tissue flaps here?
Well, the pectoralis major flap is a real workhorse, especially for neck coverage. It's pedicled, reliable, pretty easy to harvest.
Though the pedicle bulk can be noticeable. Aesthetic.
It can be, yeah. Then you have free flaps like the ALT, the anterolateral thigh flap. That's often good for posterior defects, maybe with a TMJ resection or in patients with comorbidities.
Left donor site morbidity with the ALT.
Generally, yes. Minimal donor issues, and you can often harvest it at the same time as the resection team is working.
Any others?
The VRAM vertical rectus abdominis myocutaneous free flap is another option. Similar indications to the ALT, really, based on the deep inferior epigastric artery.
But more donor site concerns with the VRAM. Abdominal wall issues.
That's the potential downside risk of weakness, hernia, or bulging.
And there was a specific point about using soft tissue alone for certain posterior defects.
Right, if you have a posterior defect but the anterior mandible is okay and you've resected the TMJ, sometimes just a soft tissue flap can give pretty decent aesthetic and functional results, and it's obviously a less complex operation.
Interesting nuance. Okay, the last initial option. Non-vascularized bone grafts. NVBGs.
Yeah, so these are bits of bone without their own blood supply. Think iliac crest, maybe rib.
Indications seem quite specific here.
Very specific. Generally reserved for smaller defects, say less than 6 centimeters, usually from trauma or maybe removing a benign tumor. And crucially, no radiotherapy planned.
Success rates drop off significantly with size.
Dramatically. Good success, maybe over 80% for defects under 6 centimeters, but it plummets to maybe 25% if you go larger than that.
The big no-nos.
Radiotherapy is the absolute main contraindication. High risk of extrusion, the graft's just melting away or getting infected. Also generally contraindicated for the anterior mandible and definitely not the first choice in cancer patients.
And timing matters too.
Yeah, often delaying the placement of an NVBG, letting the soft tissues heal first, can actually lead to better outcomes.
Right, that covers the initial thoughts, which naturally leads us towards the more definitive solutions, especially for larger or more complex defects. Vascularized, bone-free flaps.
Exactly. These offer fundamentally better biomechanical properties compared to plates or non-vascularized grafts.
They're cooler, stiffer, better union.
Yeah, all of the above. Better strength, better stiffness, much higher rates of actually achieving solid bony union or arthrodesis, and that translates to better function long-term.
So when are these clearly the way to go?
They're really the treatment of choice for any defect that's been irradiated or is planned for radiation, and also for larger bony defects, generally over that 6 centimeter mark.
Any situations where you'd hesitate?
Well, you might exercise caution in, say, very posterior defects in patients with significant comorbidities, especially if the condylar head is gone. But generally, for significant defects, this is the standard.
And importantly, lower failure rates than plates alone.
Much lower failure rates compared to just using MRPs, yes.
Okay, let's talk specific flaps. The free fibula osteocutaneous flap sounds like the main player.
It really is the workhorse for mandibular reconstruction. Its blood supply comes from the peroneal artery. You get a good pedicle length, usually 6 to 10 centimeters.
And plenty of bone length.
Loads of bone length, yeah. Average is well over 20 centimeters. Plus, you can take a reliable skin paddle with it.
Good for dental implants, too.
Very good bone stock for implants. And the donor site morbidity is usually manageable. Patients are often weight-bearing within a few days.
So what makes it so versatile? Why is it the workhorse?
Several things. You can often do a two-team approach, harvesting the flap while the resection is happening. It provides the longest segment of straight bone, so it's basically the only option for really long defects. The skin island is usually reliable for lining, minimal long-term donor site issues, and as we said, great bone for implants.
Are there downsides? Any limitations?
The main one is probably the lack of vertical height. The fibula is relatively narrow compared to the native mandible height.
So it can look a bit thin vertically.
It can, yeah. And the skin paddle, if you take one, can sometimes be a bit thick or bulky, which might make implant emergence a bit tricky later.
And outcomes. Skin paddle reliability.
Skin paddle reliability has definitely improved over the years with technique refinements. But you do see more complications if you have to do lots of osteotomies, especially if the bone segments are very short.
Okay, fibula covered. What about the free iliac crest bone flap? DCIA flap.
Right. Based on the deep circumflex iliac artery, pedicle is a bit shorter, maybe 5 to 7 centimeters. You get a good chunk of usable bone, maybe 14, 16 centimeters.
How's it for implants?
Excellent for implants. Really good quality bone. And you can take the internal oblique muscle with it on its own blood supply branch, which is great for intraoral lining.
So the big advantage is height.
Height is the key advantage, yes.
Yeah.
It more closely mimics the natural height of the mandible, plus that internal oblique muscle option, and good bone for osseointegration.
Disadvantages then?
The external skin paddle, if you take one from the groin, can be quite bulky and maybe not the best quality aesthetically. The harvest itself is definitely more involved, more time-consuming than a fibula.
And the donor site. Hernia risk.
That's the main concern. There's a recognized significant risk of donor site morbidity, particularly abdominal wall weakness or hernia. It's a bigger hit for the patient at the donor site.
Okay. Moving on to the scapular flap.
The scapular flap system. Blood supply is from the circumflex scapular artery, which comes off the subscapular. Pedicle is shorter, again, maybe 4 to 6 centimeters.
Bone quantity.
You get a decent segment, maybe 10 to 14 centimeters from the lateral border. Implant suitability is, well, it's adequate in maybe 60–70% of cases, but not as consistently good as fibula or iliac crest.
But it offers a lot of soft tissue.
That's its main selling point, really.
Right.
You can harvest very large, potentially multiple independent skin paddles based on the same vascular system. Great for complex soft tissue defects.
What are the drawbacks? Positioning, bone quality.
Positioning is when you usually need to harvest it after the resection because the patient needs to be in a lateral position, which slows things down. The bone itself is quite thin compared to the others.
And osteotomies.
It doesn't tolerate multiple osteotomies as well because the blood supply isn't truly segmental along the length like the fibula. You risk devascularizing segments.
And you briefly mentioned the radial forearm flap.
Yeah, the osteocutaneous radial forearm flap. It's an option, but the piece of radius you can take is usually quite small and thin. Generally, the bone stock isn't considered robust enough for reliable load-bearing mandibular reconstruction, especially if you need implants.
Okay, that covers the main flap options. Now, the material brought up CAD/CAM, computer-aided design and manufacturing. Virtual planning.
Right. This is becoming much more common. It involves getting detailed 3D imaging, like a CT scan, of the patient's jaw and the donor site, say the fibula.
And then you plan the surgery on the computer.
Exactly. You can virtually resect the mandible, then simulate the osteotomies on the donor bone model, figuring out the exact cuts and angles needed to recreate the jaw's shape.
And it helps create physical guides.
Yes, you can 3D print patient-specific cutting guides or jigs for both the mandible resection and the fibula osteotomies. You can even pre-bend the reconstruction plate on a 3D printed model of the planned reconstruction.
What's the big advantage of doing all that prep work?
The main claimed benefits are saving time in the operating room because a lot of the planning and fiddling is done beforehand, and potentially improving the accuracy of the final reconstruction, getting the shape just right.
Any downsides to this tech?
Well, there's obviously a cost associated with the software, the planning time, and printing the guides and models, and it does add a layer of preoperative planning time.
So let's try and summarize the key takeaways from this discussion.
Okay, I think the main message is that defect size and location really drive the reconstructive choice. That's number one.
And for bigger defects, say over 6 centimeters or anything involving the anterior mandible, vascularized bone is generally the way to go.
Absolutely. Especially if radiation is involved. NVBGs and plates alone have significant limitations in those scenarios.
And among the vascularized options, the free fibula flap seems to be the most versatile and commonly used.
It really is the workhorse, yes. Offers great length, good bone for implants, reliable skin paddle.
And finally, this preoperative CAD modeling, while adding cost and planning time, can potentially streamline the surgery and improve accuracy.
Exactly. It offers a way to enhance precision.
So it really highlights how we have this diverse toolkit now, from simple observation to complex free flaps with virtual planning, allowing for increasingly tailored approaches for each patient's specific mandibular defect.
That's right. It's about choosing the right tool for the specific job based on all these factors we've discussed.